Am I audible to everyone? Please chat in the type in the chat box whether I am audible or not. Okay, so I'm audible, right? So I'm just sharing one of my screen and this is also visible to you all. Yes or no? We will start with the genitourinary surgery and this will be like multiple choice questions and an interactive session one. Okay, so shall we start now? You ready all? You all are ready? Okay. So let's start with the first slide. How many people are there? So seven only. Okay. So let's see. So we will start with the genitourinary testes and we will do with the from the testes and the scrotum. So these are the topic which I'm going to cover. So now tell me the answer. A 1 year old male child is brought with an empty right scrotum. Okay, it's an empty right scrotum. On examination, the test is palpable. The testis is palpable in the inguinal canal. What is the most appropriate management? We will do the topic in a question wise. Okay, so it will help you to remember or to memorize also. Okay, so that I can understand and grasp the topic. Okay, so can you tell me the answer? A 1 year old male child is brought with an empty right scrotum on examination. The testis is palpable in the inguinal canal. What is the most appropriate management? Should we wait for 5 years for spontaneous descent? Start with the HCG therapy immediately. Performed orchidopexy now and orchidotomy. Okay, so C and A. So I got two question like answer C A C. Okay, so let's start with what is this actually? The diagnosis is undescendant testes. Okay, so first, what is the diagnosis from here? So one question they can ask you also in this time, what is the diagnosis? It is an undescendant testes because the scrotum is empty. Okay, so empty scrotum. Okay, and the testis is palpable in the inguinal canal. So testis does not enters into the scrotum. Okay, now what is the answer? The answer is the answer C, that is your perform orchidopexy now. Okay, we know that what is the ideal time to do the surgery? It is about 6 to 12 months, latest by 1 year. Okay, if early surgery will decrease the risk of the malignancy and also the infertility. Okay, so here will be the answer is a performed orchidopexy now. Why? Because it is a 1 year old child and we know that the most common time to do this year likely the time to be 6 to within the 6 to 12 month. Okay, so this can be one of the question. Okay, so one is what is the diagnosis and what is the actual time to do the orchidopexy in case of undescendant testes. So it's type of clinical question they can ask you in an examination. Now, what is the most common location of an undescendant testis? And it's very easy to answer. What is the most common location of an undescendant testis? There are some topics. It's okay. Let's see the answer. Undescendant testes. Okay. Is it abdominal cavity? Is it inguinal canal, prescrotal area, or the femoral canal? Okay. So everybody is saying it's abdominal cavity. Let's move. What is the answer? So abdominal cavity is the answer if it is in the ectopic testes. Okay, but here the undescendant testes, the most common location is the inguinal canal. Okay, the answer is B. What is the most common location of undescendant testes? Your answer is B. Okay, and undescended testes is usually seen in 3% of the full-term newborn. Usually about 70 to 75% undescended testes, it will descend normally by the 3 month of age. Okay, the undescended testes will descend normally by the 3 month of age. And the most common abnormal location for the undescended testes will be the inguinal canal. Okay. Okay, now undescended testes is associated with the increased risk of renal failure, testicular torsion, prostatitis, and the varicocele. Just write it here. So, what is the descent of the testes? So let's see the answer. Yes. So important one is it is your testicular torsion. So what is the complication? Write it here, the Sathi, SATHY. Okay, one S for the seminoma, that is the most common tumor of the undescended testes. If the testes in the abdominal cavity, the most common tumor will be the seminoma. And most above the testes, there are more chance to develop the cancer. Okay, so S for the seminoma, A for the atrophy, T for the torsion, H for the hernia, and I for the inflammation. So these are the increased risk factor for the undescended testes. Okay, more higher the testes, more chances to develop the carcinoma of the testes. Okay. Now testicular descent. Let's see the pathway of the testicular descent. It starts from the second month. Okay, write it down. It starts from the second month. It begins to the testes started to descend to the second month, and from the to the third month it reaches to the iliac fossa. Okay, IF is the iliac fossa in the, and from the second month it begin to descent. Okay, in the third month it reaches into the iliac fossa. In the fourth month it enters into the deep inguinal ring, DIRE is deep inguinal ring. By the seventh month, it enters into the inguinal canal. IG is your inguinal canal. In the eighth month, it enters into the superficial inguinal ring. Okay, superficial inguinal ring, and by the ninth month, it enters into the scrotum. So you should know this is basically anatomical questions. Okay, the testes descent. Okay, and which in where the testes in which month the testes is lying in the deep inguinal ring. Okay, so this is basically one of the anatomical question and very important for your multiple choice in your AIPGT examination. Okay. Okay, now
मैम एक बार फिर से बता दीजिए मैम.
ये testes descent, it start from the second month. Okay, the testes descent is start from the which month? From the second month. By the third month, it enters into the iliac fossa. By the fourth month, it enters into the deep inguinal ring. By the seventh month, it enters into the inguinal canal. Okay, and by the eighth month, it enters into the superficial inguinal ring, and by the ninth month, it is in the scrotum. Okay, got it? समझा?
Yes ma'am, thank you.
So अभी इसका आंसर बताओ. The most appropriate age for the surgical correction. This we have done just now. So it is about 6 to 12 month. Okay, 6 to 12 month. Very good. Okay, and what is the most, if they ask you the investigation of the choice, then your answer will be your inguinal exploration. Okay, inguinal exploration. So this covers basically your undescended testes. Okay. Renal anomalies is also there, but it's only into the 10% cases, and most common tumor, if you found, it is seminoma. Okay, the most common testicular tumor in undescended testes will be the seminoma. Okay. Now, which of the following is not a complication of the undescended testes? Infertility, testicular malignancy, urinary incontinence, inguinal hernia. Okay, let's see the answers. Very good. It is urinary incontinence. ठीक है. Most common malignancy will be the seminoma. ठीक है, ये भी याद रखना. So this is the basically mnemonic for the malignancy of the what are the like complications of the testicular tumor. Now, 25-year-old man or 25-year, okay, the age present between intra-abdominal and descendant testes. So it is in the intra-abdominal, so it is in the abdominal part, okay, not in the inguinal region or anywhere. So which of the following statement is true? Risk of the malignancy becomes equal to the normal after auriculopexy. Most common tumor is teratoma. Auriculopexy reduces the malignancy risk but does not eliminate it. Biopsy is mandatory after the surgery. We will go slowly so that it will help you to grasp. Okay, just give me the answer quickly. Okay. Let's see what is the answer. C. Good. Anybody? Anybody? Okay. So let's do one by one. Okay. Most common tumor is teratoma. We know that the most common tumor will be the seminoma. Okay, so second option will be opt out. Okay, it's not a correct answer. Risk of malignancy become equal to normal after auriculopexy? No, it reduces it but does not eliminate it. So remember, auriculopexy does not decreases the risk. Auriculopexy does not decreases the risk. Okay, but it is basically it helps in the early detections also, but does not decreases the risk. Okay, but it reduces the malignancy risk but does not eliminate it. Okay, that does not eliminate it. So answer will be your C. Biopsy is mandatory before surgery? No, it is not mandatory before the surgery. Okay, so most common tumor will be the seminoma. Risk of malignancy becomes equal to normal after auriculopexy. Auriculopexy does not eliminate it, but basically reduces the risk. Okay, but it's still there. There is a risk to develop your carcinoma. Okay, so the answer is option number C. So undescended testes, more the risk of the testicular cancer, especially the seminoma. Even after the auriculopexy, risk persist, but early age helps detections. In adult, after auriculotomy, preferred non-functional plus the high cancer risk. Okay, so this इसको याद रखना. Okay, the explanation. This helps you to give the other answers also. Okay, let's move to
Ma'am,
the other part.
fourth option, ma'am. Fourth option. Biopsy वाला
Biopsy
ma'am.
is not mandatory before the surgery. After it's not mandatory. Okay. ये नहीं, answer is C ही है. Okay. So now tell the answer of this. A testis which is found outside the normal path of the descent. So it's termed as what? Retractile testes, vanishing testes, cryptorchism, or the ectopic testes. नॉर्मल डिसेंट से अलग पाथ में अगर जाता है तो उसको क्या बोलते हैं? Yes, it is ectopic testes. Okay, and if the question asks what is the most common location for the ectopic testes, okay, what is the most common location for the ectopic testes? Your answer will be
Abdomen.
superficial inguinal pouch. This is the most common location. Other than this, femoral region, femoral canal, that is your perineum, suprapubic region. Okay, And remember, most of the ectopic testicles can be felt. Most of, not all, okay? Not all, okay? Most of the ectopic testes are palpable. These are the some pointers they can ask you in the examinations. They can ask you the common locations. Okay, and remember they have most liable to injury. And ectopic testes, they're usually fully developed, but they do not follow the normal path. Okay. Now, ectopic testes is characterized by the testes lying along the normal path of the descent, or testes located outside the normal path of the descent, absence of testes, or the retractile testes not moving freely. Common location is superficial inguinal pouch. The common location is of ectopic is or superficial inguinal pouch. Okay. Yes, the answer is C. Okay. The most common site for the ectopic testes, it is superficial inguinal pouch. Okay. Okay. Now come to the testicular torsion. Okay. Another one, that is your testicular torsion. So basically, they are the two types. One is your intravaginal and the other is extravaginal. Okay, wait with me. So one is intravaginal torsion and other is your extravaginal torsion. Difference is torsion twisting the spermatic cord along with the tunica vaginalis. But here in the extravaginal torsion, that is twisting occur of the spermatic cord along with the tunica vaginalis, but also occur outside also. So twisting can with the, that is the torsion, that is twisting of the spermatic cord along with the tunica vaginalis, that is entire testes also, and the covering the twist or the covering part also, that is occurring outside the tunica. So one is within the tunica vaginalis and other it some out it like twist the outside part also. That is only the difference. Another is intravaginal. It is most commonly seen in the young adult. Okay, so the common age will be in within the 10 to 25 years of age, seen in the adolescent or in the young adult. Okay, they are seen in the adolescent and the young adult. And here they are seen in the newborns, okay, the neonates. That is the extravaginal torsion. And remember one thing, the more common deformity for the intravaginal torsion will be the bell clapper testes or the bell clapper deformity. That is testes freely mobile within the mobile inside the tunica vaginalis due to the, and it is in the horizontal position. So this bell clapper deformity, it is the most anatomical cause for the intravaginal torsion, not for the extravaginal. And for the extravaginal, because it is a neonatal, so mostly due to the poor fixation of the testes to the scrotal area. So mostly due to the poor fixation of testes to the scrotal wall, which is normal in the some neonates. Okay, so what is intravaginal? That is twist inside the tunica vaginalis. Extravaginal, that is twisting with tunica vaginalis. It's covering also along with the spermatic cord and outside the tunica vaginalis. Intravaginal torsion usually occurs in the adolescent and the young, but extravaginal most commonly in the neonates. Okay. And what are the clinical features? These are the classical presentation mostly in case of the intravaginal torsion. Okay. There is a sudden severe scrotal pain, pain in the abdomen which is radiating to the groin, nausea, vomiting, high riding, okay, horizontal line. The horizontal line is bell clapper, deformative, Okay, if it is in the extravaginal, there is some pain, but mostly they are the painless. Extravaginal torsion, they are mostly present at the birth or soon after the birth, and they are basically painless. And if there is an painless but firm swollen testes. Okay, that is your they are non-tender testes. Okay, and they are usually present just after the soon after the birth. And these are the some of the clinical feature of the classical presentation of the uh, testicular torsion, intravaginal torsion. So cremasteric reflex is absent. Okay, remember the cremasteric reflex is absent in testicular torsion, and it is help you to differentiate between the testicular torsion and the epidermoorchitis. Okay, so what is what is cremasteric reflex? If you scratch inside the inside area of the thigh, okay. So suppose stroke the medial thigh downward, there is a retraction of the testes upwards. So this is called cremasteric reflex. As the testicular intorsion, the testis is already in the high rising, so that is why the cremasteric, you won't find the cremasteric reflex in the testicular torsion. So testicular torsion is helping to differentiate between the epidermoorchitis. In epidermoorchitis, if you scratch the middle side of the thigh, the opposite, the ipsilateral, that the same side of the testes, it retract to the up, yes, above, upside. Okay, what is written here? Okay, nothing. Okay, so this is your differentiation between the testicular torsion and the epidermoorchitis. Okay, so yeah, it is help to differentiate between the from acute epidermoorchitis. In case of torsion testes, affected testes at the higher level. Okay, this is because of shortening of the cord, and because of that, cremasteric reflex is absent in the testicular torsion. Okay. Now, yeah. So this is also known as your, so Demin sign. What do you mean by the Demin sign? Demin sign means the affected testes at the higher level. Demin sign means your the testes at the higher level because of the twisting of the cord. Higher level because of a twisting of the cord. So this is called your Deming sign. Okay. Investigation of the choice for the testicular torsion will be the colored Doppler. Colored Doppler. Okay. What is angel sign? It refers to the high rising horizontal lie of the affected testes seen in the testicular torsion. So opposite testes lies horizontally because of the presence of the twisting of the cord. Okay, now one is, this is what same thing. This is known as a Freyne sign. Okay, this is called your Freyne sign. There is an Freyne sign. Remember, the cremasteric reflex is also absent, and the Freyne sign is also negative. Now, what is a Freyne sign? So when you elevate the testes, the pain is relieved in the epidermoorchitis. Okay, so when you elevate the scrotum, the pain is relieved in the acute epidermoorchitis, but it is present, it gets severe in the testicular torsion. Now this is called basically French sign. When there is a negative, it is called your acute, it is French sign is positive in the acute epidermoorchitis. When you elevate the scrotum, the pain decreases. That means French sign is positive. And when you elevate the scrotum, there is no decrease in the pain. So this is in the So here the French sign is negative. Okay, so French sign is negative in the testicular torsion. Okay, this is also help you to differentiate between the testicular torsion and the epidermoorchitis. Okay, so let's move to the some important MCQs. Which of the following statement about the intravaginal testicular torsion is true? Intravaginal testicular torsion. Just tell me the answer. It is most common in the neonate. Involve this twisting of the spermatic cord outside the tunica vaginalis. Associated with the bell clapper deformity, usually revolves spontaneously without surgery. Let's see the answer. Yes, it is associated with the bell clapper deformity. Very good. Now go to the another one. So match the following. Friend signs, Demon sign, and the angel signs. What is friend sign? What is angel sign? And this absence of the cremasteric reflex. Lifting the scrotum relieves this pain. Testes lies transversely in torsion. Okay. So remember one thing, frame sign is lifting this, that is scrotum, it relieves the pain. 1A. 1A. Yes, 1A. Demen sign and the absence of cremasteric reflex. Can you tell me what is the cremasteric reflex? Absence of cremasteric reflex, that is 2 का C. और किसने क्या आंसर दिया है? Very good. 1A, 2C, 3B. Right. So let's see the answer. Deming sign seen in the testicular torsion where the testes lies horizontally refers to the loss of the cremasteric reflex, also seen in the torsion. Okay. So angel sign is loss of the cremasteric reflex. So this is one. Demon sign is testis lies transversally in the torsion, and angel sign absence of the cremasteric reflexes. Okay. Let me see. Yes. Now, can you tell me this answer? Varicocele is most commonly found in right, left, both side, and scrotal septum. Just give me a few minutes. Varicocele is most commonly found in the right side, left side, both the side equally, and the scrotal septum. Okay. So let's see the answer. It is in the left side because the left testicular vein drains into the left renal vein at a right angle, which increases the risk of the venous backflow. So, sorry, the answer is left side. Okay, so ये one word question है, इसको याद रखना. Varicocele is most commonly in the left side. If it is right-sided varicocele, though suspicious there might be due to the renal cell carcinoma. So it will be a suspicious lesions. If it is on right side, it will be a suspicious varicocele due to the renal cell carcinoma. Okay, this is very important. Suspicious, maybe this is, if it is right-sided varicocele, this it's suspicious, maybe secondary due to the right cell carcinoma. Okay. Now, the clinical appearance of the varicocele is often associated with bag of stones, bag of worms, smooth round swelling, Dowgy mass. Can you tell me the answer? Let's see क्या क्या आंसर है. B. Very good. So the clinical appearance of the varicocele is often described as a bag of worms. Most commonly seen in the young adult. They are mostly painless. Pain नहीं होता है. Okay, and most commonly in the left side, and they basically do not regresses by its own. The varicocele do not regresses spontaneously, and they are associated with testicular atrophy. Testicular atrophy. Okay. So if there is an atrophy, always they affect the spermatogenesis also, because increase temperature, rise of the temperature decreases the spermatogenesis. And investigation of the choice will be the Doppler. Okay, so basically the clinical examination by the diagnosis is made by the clinical examination and confirmed by the color Doppler. Okay, color Doppler. In the color Doppler, we will see the reverse flow. Okay, we will see the reverse flow. But if they ask you what is the gold standard diagnosis, the gold standard diagnosis will be the venography. Okay, varicocele is associated with increased sperm motility, testicular hypertrophy, infertility due to increased scrotal temperature, pain relieved by standing. Yes, it is infertility due to increased total temperature. Good. Now, this is very important. The nutcracker phenomenon, that is superior mesenteric artery, it sandwiches and squishes the left renal vein. So, compression of the left renal vein between the superior mesenteric artery and the abdominal aorta, which lead to the venous congestion. So, this is called nutcracker phenomenon. इसको याद रखना. This is your okay, pointers. What is nutcracker phenomenon? When the compression of the left renal vein between the superior mesenteric artery and the abdominal aorta, okay, caused by the compression of the left renal veins between the aorta and the superior mesenteric artery, leading to the venous congestion. So, can cause secondary left-sided varicocele. There will be hematuria, left flank or abdominal pain, left-sided varicocele due to increase in the left testicular vein, renal hypertension, and most commonly if it is left-sided, associated with left-sided varicocele, there is a renal vein hypertension. Okay, so these are some of the secondary and functional effect of the left-sided varicocele. Now come to the acute epidermolysitis. So if the question asks what is the most common causation for the acute epidermolysitis, it is mostly due to the ascending infection from the lower urinary tract. So usually if it is in the men of 35 years of age, most commonly due to the sexually transmitted organisms, that is your childema trachomatis and the Neisseria gonorrhoeae. Okay. So trachomatis, this is the most common, followed by the Neisseria gonorrhoeae. If it is in the children, then the most common will be the Escherichia coli, E. coli. Okay, the most common will be the E. coli. Okay, so if it is in adult, the most common organism will be the C. trachomatis, most common, followed by the Neisseria gonorrhoeae. In children and the older men after 60 years of age, the most common will be the Escherichia coli. Okay, and what is the clinical feature? Clinical feature will be the patient will complain or come to you with the fever due to the fever and tended scrotum. The scrotum is tender, red, tended scrotum. Okay, it become thick, it become tender. Okay, the epididymis and testes become swollen. And if you do the urine analysis, it typically basically shows the uh, uh, demonstrates the WBC and the bacteria in the urine. Okay, so basically urine culture will show the bacteria. And if you go with the ultrasonography, it will show your thickened cord. It will show the second cord. The most important clinical feature, that is the question they can ask about the children, the most common causative organism, and the old people after 60 years of age, and also in the homosexual. Okay, in the homosexual also, the causative organism will be Escherichia coli, whether in the adult it will be your Neisseria gonorrhoeae and Chlamydia trachomatis. This is all about your acute epidermolysitis. Okay. Hmm. Yes. Okay. So these are the some of the one of the question. A 70-year-old boy present with scrotal pain for 10 years, 17 year. Okay. Pain started gradually and associated with low-grade fever. On examination, the testes is tender and swollen. Pain decrease on elevation of the testes. Pain decrease on elevation of the testes means French sign is positive, a case of acute epidermolysitis, and the cremasteric reflex is present. So this is a diagnosis of acute epidermolysitis. Which of the following finding will most likely to be seen in the Doppler ultrasonography? Is it absent intra-testicular blood flow, decreased venous flow with normal arterial flow, increased blood flow in the testes and the epididymis, and twisting of the spermatic cord? Okay. So whenever there is a severe pain, whenever there is a fever, there is a severe pain, there is an increased blood flow. Okay. So the answer will be C. That is increased blood flow into the epididymis and the testes. The answer is C. Okay. So these are the basically the differentiator factor. Torsion is sudden, epididymitis is gradual. Age in the teenagers, they mostly in the adult, but if it is in the old children, to the Escherichia coli. Okay. So now come to the hydrocele. See another thing. So testes and scrotum, and we will come to the hydrocele now. Yes. Hmm. See anything I miss? Okay, now a 3-year-old child is brought in painless total swelling that increase on crying and decrease on lying down. On examination, swelling is transilluminant and you get above the swelling. What is the most likely the diagnosis? Vaginal, encysted, congenital, hydrocele. Okay. So पहले इसको समझते हैं. There are the various types of the hydrocele. Let's first go to the type of the hydrocele. Okay, then we will give the answer. Okay, so I think okay, let's move to the type of the hydrocele first. So here the answer will be basically the congenital one, okay, because the swelling is transmullin and above the swelling is there. Okay, so first see what are the type of the hydrocele. I think I have not written here. So one is the most common hydrocele. If they ask, your answer will be a vaginal hydrocele. Okay, vaginal hydrocele means accumulation of the serous fluid in the tunica vaginalis, within the tunica vaginalis. So the serous fluid in the tunica vaginalis, this is the most common. Congenital hydrocele, it is also known as your communicating hydrocele. It is mostly due to the patent process vaginalis. Okay, the congenital hydrocele, it is mostly due to the patent process vaginalis. It is mostly due to the patent process vaginalis. Okay, there are the another hydrocele which is known as our infantile hydrocele. Here the does not appears in the infant, but the tunica and the process vaginalis are distended and they have a connection with the peritoneal cavity. Okay, they have a connection with that of the peritoneal cavity, and this is called your infantile hydrocele. Infantile hydrocele means there is an connection within the peritoneal cavity. Okay, the tunica vaginalis and the process vaginalis are distended to the inguinal ring and they have a connection up to the peritoneal cavity. So there is a fluid within the peritoneal cavity in case of infantile hydrocele. In case of infantile hydrocele. Okay. So here, remember, in case of this, a 3-year-old boy is present with painless scrotal swelling. Hydrocele is mostly painless. Okay, and trans illumination test is always positive because the fluid is there. But when you with the help of the torchlight, if you squeeze the light on it, you will see a trans illumination test will be positive. Okay, so in hydrocele, trans illumination test is always a positive. And in case of congenital hydrocele, because it is in patent, when the patient lies down, the swelling decreases. Okay, so the answer will be your congenital hydrocele. Why? Because of the fluctuation in the size, it indicates communication with the abdomen. Okay, and because it is you get above the swelling, that is why the answer will be a congenital hydrocele, not the infantile one. Infantile is also have the same thing, but they have a communication with the peritoneal cavity. So here the fluid enters into the peritoneal cavity. Okay. So in vaginal hydrocele, there is a no size change. Okay. Even if the patient is in the lying down or in the standing position. Okay. Encysted hydrocele, there is an separate quad swelling. Okay. 1 minute. Let me see what is the encysted hydrocele. And inguinal hernia is not a chapter because trans illumination test is not positive in the inguinal hernia, and you won't get the above the swelling is a feature of inguinal hernia. Okay. And about the encysted hydrocele, let me see. The encysted hydrocele is here the fluid collects within the spermatic cord. Okay, in encysted hydrocele, here the fluid, it collects along the spermatic cord, okay, along the spermatic cord, which separate from the testes. So there what you will find? You will find a swelling in the spermatic cord. The fluid get trapped and it forms a closed cyst, okay. And here it is, nothing it is written that whether there is a swelling in the spermatic cord or not. So the answer will be congenital hydrocele. So in vaginal hydrocele there is a no size change. Inguinal hernia transillumination test is negative, okay. And encysted hydrocele of the cord, there is an accumulation of the fluid within the spermatic cord, in the spermatic cord. So there is a swelling of the spermatic cord, which is not a feature in the question. So the answer will be your congenital hydrocele. Okay. So anything or kuch, acute epidermolitis and hydrocele. Okay. Now move to the next part about your hypospadias. ठीक है. सो हाँ, पहले क्वेश्चंस करते हैं, उसके बाद से हम लोग एक के बाद एक करेंगे. ठीक है. So can you just tell me, in hypospadias, not the epispadias, okay, hypospadias, the urethral opening is located on the dorsal surface of the penis, at the tip of this penis, on the ventral surface of the penis, or inside the bladder? Which one? In hypospadias, where the urethral opening is present. The urethral opening is present in the ventral surface or the dorsal surface, or on the tip of the penis and inside the bladder. Okay. Remember in hypospadias, so suppose this is a hypospadias, and most of this opening, if you see, in the ventral surface of the penis. Okay, the typical urethral opening should be here, but the urethral opening is abnormal in the hypospadias. It can be in the glandular, subcortical, distal penile, mid shaft, in the ventral surface of the penis, not the dorsal surface. Okay, so the answer will be on the ventral surface of this penis. Now, the type of the hypospadias, one is your glandular, subcoronal, distal penile, proximal penile, pinoscrotal, scrotal, and the perineal. Remember, circumcision should not be done in the patient with the hypospadias. Okay, remember one thing is circumcision should not be done in case of the hypospadias. So glandular, one is your glandular, subcoronal, distal penile. These are the anterior form. Okay, so these are the anterior form, and these are the posterior form of the hypospadias. Among this, anterior form is more common than that of the posterior form. Okay, is more common than that of the posterior form. And also in anterior form, the most common will be the distal penile or the coronal. Okay, the most common will be the coronal or the distal penile in case of anterior form. Now, which of the following commonly associated with the hypospadias? Phimosis, cryptorchism, varicocele, or the hydrocele. So basically it is an associated abnormalities. So what are the associated abnormalities of the hypospadias? Okay, one is say phimosis, cryptorchism, varicocele. Anybody? So the answer will be your Kiptor-Keedams. Okay, so basically the another R will be the inguinal hernia. Okay, inguinal hernia. If phimosis is there, you should do the circumcision. Okay, but in hypospadias, circumcision should be avoided. Other associated are the inguinal hernia and the urinary tract abnormalities. Okay, urinary tract abnormalities. These are the associated abnormality, and the most common will be the cryptorchidism. Okay. Okay, let's move to the next part. Okay, so undescended testes is the most common associated of the hypospadias. Its other name is your cryptorchism, and other are the inguinal hernia and this. Okay, so okay, so this is all about your hypospadias. There is another one which is called as your epispadias. In epispadias, the urethral is opening in the dorsum aspect. Okay, इतना याद रखना, dorsum aspect of the of the penis, and it is basically most commonly associated with your ectopic vesicae, okay, or the extrophy of the bladder. What are the associated complaint and anomalies associated with epispadias? One is your extrophy of the bladder, means the bladder is in the another place of the abdominal cavities, and the vesicoureteric reflex. Okay, so this is an epispadial. Here the opening into the dorsum aspect, and whereas in the hypospadias in the ventral aspect. Now come to the posterior urethral valve. Okay, so first just go with the question, then I will move into the posterior urethral valve topic. Can you tell me the answer? A male neonate present with poor urinary stream and palpable bladder. Antenatal ultrasonography shows bilateral hydronephrosis. Okay, so bilateral hydronephrosis is there. Okay, with oligohydramnios, and postnatal ultrasound shows thick wall bladder and dilated posterior urethra. Which of the following is the most specific diagnostic investigation? Okay, so is it your which of the following ultrasonography, IVP, voiding cystourethrogram, and the MRI pelvis? Okay, so basically this diagnosis is about your posterior urethral valve. Okay, the diagnosis will be a posterior urethral valve, a neonate at an infant. It is present with the poor urinary streams and the palpable bladder. Let's move to the what is posterior urethral valve. So उसके बाद ये आंसर आप लोग देना, ठीक है? I'm not going to give the answer right now. Let's move first. What is posterior urethral valve? Okay. So what is this? Basically here in this part there is membranous fold is present. So systemical membranous fold is usually present in the distally from the posterior urethra. So if there isn't too much a fold is present, what happened? The urine can't flow through it. Okay, urine can't flow through it. So usually this is type of the congenital disorder seen in the neonate, especially in the boys, that is a male urethra. The first pointer is a most commonly in the male urethra, most commonly one of the congenital disorder in the male, exclusively in the male. What happened? There is a formation of the membranous fold in the distal part of the posterior urethra. As a result, the urine cannot flow through this opening as there is an obstruction. So what happened if there is a no urine flow? There is a backup of the urine. Okay, so what happened if there is a backup of the urine? you will see there is a bladder is distended. Okay, so there is an accumulation of the urine in the bladder. So bladder is distended. There is a backflow of the urine to the ureter. Okay, so which resulting in the later stage will be the kidney problems and then the ascites. This type of the posterior urethral valve in the infant and the neonate seen in the associated with the oligohydramnios, renal parenchymal dysplasia, and the pulmonary hyperplasia. This is basically the most common cause of the death because of the less amniotic fluid, oligohydramnios. There is a respiratory problems resulting in the pulmonary hyperplasia, which causes the most common cause of the death. Okay, and investigation of the choice will be the mictocystourethrography. Okay, so this is all about your posterior urethral because it is in development. There is a disruption in the development in the posterior part of the urethra, especially in the 9 to 14 weeks. Okay, 9 to 14 weeks. Now here the answer will be avoiding cystourethrogram. Okay. So here what is the most specific diagnostic investigation, that is avoiding cystourethrogram or the mictocystourethrography, MCU. Okay. So this is a clinical feature of posterior urethral. A patient is neonate, an infant. Okay, this is a male patient, male boy. Okay, sorry, male urethra with poor urinary stream and palpable bladder. Okay, so what is, and the antenatal USG will shows your hydronephrosis and the oligohydramnios. So this all shows a feature of posterior urethral valve. Okay, it's a congenital obstructive disorder of the, especially in the male urethra. Okay. So it is a gold standard diagnosis. Dilated posterior urethra, keyhole sign, and the vesicoureteric reflex. Okay. USG can suggest, but it cannot confirm the diagnosis. For confirming, you have to do the voiding cystourethrogram. Okay. Now come to the another feature of a phimosis and the paraphimosis. इसका सिर्फ what is the differentiation between the phimosis and the paraphimosis? इतना करके ही रखो. Phimosis, where the foreskin cannot be retracted. Here the retracted foreskin cannot brought back over the glands. ठीक है? Usually it is in chronic condition. It is congenital also, and it is acquired also due to some diseases. Okay, some balanitis, trauma, or anything. Okay, acquired. But paraphimosis is always acquired. It is never congenital. This is another thing. Paraphimosis is always acquired. Okay. Position covers the glans, tightening, retracted behind the stuck. So glans penis is not visible. It is exposed swollen and edematous, which resulting in severe pain. It may cause urinary obstruction, but in phimosis, difficulty in bellowing of the foreskin. Complications will be balanitis, and this will be the ischemia, which resulting into the gangrene of the glans. Okay. So paraphimosis, chronic inflammation, which resulting into the contracture, retractor of the foreskin, and which cannot goes back. Okay, circumcision is needed in phimosis, topical steroids, and here also the same thing, paraphimosis. If conservative method fails, we have to go with the circumcision. Okay, so these are the basically the difference between the phimosis and the paraphimosis. Remember, the circumcision should be done if no response to the medical treatment, and age should be within 16 to less than 16 to 18 years of age, more than 16 to 18 years of age, sorry. So these are the differentiate between this phimosis and the paraphimosis. Okay, now a 45-year-old male present with the painful penile erections. Can you tell me what is the diagnosis and curvature of the penis during intercourse? On examination, and palpable plaque is found. What is this actually? So if you see, what is the first diagnosis? Can anybody tell me क्या हो सकता है ये? A 45-year-old male present with painful penile erections. Erections are there, but it's very painful. And there is a curvature of the penis during intercourse. On examination, palpable plaque is felt. Okay, so basically this is a feature of a Perinois disease. Okay, this is a clinical feature of a Perinoid disease. What are the clinical feature? एक तो होगा usually in the old people, right? Second, there is a painful penile erections with curvature of the penis during intercourse. Okay, so this is important clinical feature of this Peyronie's disease. What happened here? There is a formation of the plaque. Formation of the plaque in the fibrous plaque, especially in the dorsal aspect of the tunica albuginea, especially where, okay, and the plaque is in the where, that is dorsal aspect of the involving the tunica albuginea, which result goes into the calcification. So their answer will be the C. So one of the clinical feature is painful penile erections, two is curvature, third is fibrous plaque, and where it is present in the dorsal aspect of the tunica vagina. Okay, this is called Peyronie's disease. And this Peyronie's disease is also associated with the three triad. Okay, the triad name is your Galizia triad. Dupuytrenal contractures, Peyronie's disease, and the retroperitoneal fibrosis. Okay. So this is the curvature is in the upward curvature, याद रखना, ठीक है, in the upward curvature and formation of the fibrous plastic tunica albuginea. And here this is Dupuytrenal contractures, Peyronie's disease, and the retroperitoneal fibrosis. Okay. Chalo. Okay, so let's move to the another one, which is called your urethral injury. I'm going into some detail so that it's help you to identify. चलो, अभी urethral injury में basically two type की injury है. One is your anterior urethra and other is your posterior urethra. Okay, in anterior urethra, the most common will be the bulbomembranous junction. Okay, the most common will be the bulbal urethra, or that is the most common is your not in the anterior one, that will be in the, this is anterior and this one is the posterior. So in the posterior, the most common will be the bulbomembranous urethral junction. Okay, so bulbomembranous junction, the most common area prone to urethral injury in posterior urethra is, your answer will be bulbomembranous urethra. Okay, this is the most common in the liable to injury in the posterior urethra, whereas in the anterior urethra, it is the most common site is the bulbar one. Okay, the most common is injury prone to injury in anterior urethra is the bulbar. Okay, so site anterior urethral injury and the posterior one. Anterior urethral injury involves the bulbar and the penile, most common the bulbar. Okay, posterior urethral injury involves the membranous and the posterior urethra, most common is the bulbomembranous urethra. Okay, anterior urethral injury, it is mostly due to the fall on a bar or a bicycle straddle injury, and here road traffic accident due to the pelvic fracture. Okay, so common feature, common blood at the meatus is common. Urination may pass urine with difficulty, but in posterior they cannot pass the urine. Only the per rectal examination, the prostate is in normal prostate, and in posterior there is a high rising prostate. So if you go with the intravenous pyelography of posterior urethral injury, you will see a pie in the sky. It looks like a pie in the sky on IVP in case of a posterior urethral injury, that is bulbomembranous posterior urethral injury. Okay, structure, incontinence, these are some common clinical features of both the anterior and the posterior. Okay, so here you should note down the cause, that is manhole injury, fall on a bar. Okay, so anterior urethra, plus there is a retention of the urine is present in both the cases. Blood is at the meatus present in both the cases, but here the prostate is normal lying and here the prostate is non-palpable and it is high rising prostate. That is pie on this, on IVP you will see a pie on the sky. Okay, difference between the anterior and the posterior. Now, can you give me the answer? Posterior urethral injury is most commonly seen in the fall in the perineum, straddle injury, penile one, pelvic fracture. Thinking of completing the GOT today, but I don't think so. I can complete it. So, which clinical finding is more suggestive of posterior urethral injury? फटाफट बताओ. Posterior urethral injury. Which clinical finding most suggestive of the posterior urethral injury, especially in the IVP में या तो ultrasonography में क्या दिखेगा? Pie on the sky, high rising. Okay, so that is non-palpable prostate and the high riding prostate, not the perineal hematoma. This is the posterior urethral injury. So look at the answer in this, high riding and the non-palpable prostate. Okay, on the per-rectal examination. Okay, so here the answer is the most clinical finding and the most suggestive of the posterior urethral injury will be high riding non-palpable prostate. ठीक है? Okay, got it. Now move to the, ये खत्म हो गया urethra and the penis. आधे घंटे में खत्म करते हैं prostate and the prostate and the seminal vesicles. Okay, so we have finished the anterior urethral injury and the posterior, hypospadias, epispadias. Now come to the prostate. Okay, so okay, now first will be the benign prostate hyperplasia. Okay, remember there are the two zones in the prostate. One is your peripheral zone and another is your transition zone. Okay, so 1 minute. I think there isn't anything. Yeah. So if you see the peripheral zone and other is your central zone, transitional zone, and the fibromuscular zone. The peripheral zone, most commonly the carcinoma of the prostate occurred in the peripheral zone. This can be one of the MCQ. Okay. And BPH is most commonly in the transitional zone. Okay. Usually 20% of the cases, 1 minute. Wait. Okay. Um. So BPH. So one is your 41 to 50 years of age. Then after 50% in the 51 to 60 years of age and more than 90% older is your 10-80 years of age. Okay. Just wait for 2 minutes. I have some call. ठीक है. So ये आप लिख लो. What are the clinical features? One is your obstructive symptoms and other is your irritative symptoms. Okay, so obstructive symptoms will be the hesitancy, weak urine flow, intermittent straining to pass the urine, incomplete emptying of the bladder, okay, and terminal dribbling. 1 minute, huh? Just So just write it down. What are the obstructive and the irritative symptoms of the benign prostate hypertrophy? Imaging, the diagnosis will be the ultrasonography. USG is recommended. Okay, another is your uroflowmetry. In the uroflowmetry, to know the quantity, maximum quantity where how the urine is flowing. Okay. Now tell me which symptom is the most characteristics of the benign prostate hypertrophy. Suprapubic pain, hematuria, hesitancy, and the weak urinary streams, or the incontinency with urgency only. Okay. So hematuria and the suprapubic symptoms are not there. Difference between the hesitancy and the weak urinary stream and incontinence with the urgency only. Okay. So these are the classic obstructive symptoms caused by the enlarged prostate of the urethra. Okay. So if you go with the like hesitancy, okay, hesitancy and the weak urinary stream. Okay. So the answer is C. So this is the most common feature for the obstructive symptoms. And irritative one, due to the bladder irritation, frequency, urgency, nocturia, urge, incontinence. Remember, first the symptoms will be the obstructive symptoms and then the irritative symptoms. Okay, so the answer will be C. Now, which of the following investigation is most useful to assess the severity of the urinary obstruction in the BPH? Severity. Okay, what is the size of the BPH? We do not have to see. So what is how the severity? To know the severity, we should know the in which way the urine is flowing. So can you tell me the answer? Yes, the answer is uroflowmetry. Serum PSA is there, but serum PSA is usually increases in any type of the BPH, and usually they are the prostate, not the cancer bonded. We will turn to the later part. Okay, पहले uroflowmetry का ये देख लो, that is maximum flow rate. Normal will be the more than 15 ml per second, and obstruction will be less than 10 ml per second. Okay, so this is one of the important about the uroflowmetry. Okay, now come to the tumor marker of the carcinoma of the prostate. Okay, now first the carcinoma of the prostate. Its tumor marker one is your prostatic acid phosphatase. Okay, prostatic acetic phosphatase. Another is your alkaline phosphatase. Alkaline phosphatase. Hepsine and the DD3. Okay, hepsine, DD3, and the PSA, prostate specific antigen. Remember, this prostate specific antigen is a prostate specific, not a cancer specific. Okay, its normal value of the, remember this PSA basically a glycoprotein enzyme, and it basically a prostatic specific, not a cancer specific. It is prostate specific. Okay, so value should be less than or equal to 4 nanogram per ml. Okay, if the value is more than 20 nanogram per ml, it is a diagnostic of the carcinoma of the prostate. So level of the PSA will determine the burden on the prostate. More the PSA, more the burden on the prostate. Okay, so these are the some of the normal level. But remember that is normal value will be less than or equal to 4 nanogram per ml. ठीक है, so a normal PSA level. Okay, so हाँ, और एक था in the PS में, that is most common cancer in the CA prostate. This is the most common cancer in the male and most common cause for the bone secondaries. In case of female, it is a female breast cancer. The most common bone secondaries, the breast cancer. In case of CA prostate, on male, the most common cause for the bone secondaries is the CA prostate. And the best screening protocol, okay? The best screening protocol would be PSA plus a digital rectal examination. Digital rectal examination. Sometimes they can ask what is the most common type of the CA prostate. Your answer will be adenocarcinoma. Adenocarcinoma, and which is followed by the transitional cell carcinoma. Most common in the peripheral area. So if you see the carcinoma of the prostate, the most common zone will be the peripheral zone. This is the most common zone. Okay, about 75 to 80% of the CA prostate occurred in this, followed by the transitional zone only 10%, and the 5% in the central zone. Okay, 5% in the central zone. And in CA prostate, now come to the clinical features. Most commonly, they are the asymptomatic, or they will produce all the symptoms of the benign prostate hypertrophy. Okay. Now, the common spread is through the blood, and from the blood it goes into the bone, and the most common is your lumbar vertebra. Most common site will be the lumbar vertebra, osteoblastic secondaries. In the visceral metastasis via the blood, okay, so in the bone, which bone? Lumbar bone. In the viscera, the most common will be the lungs. Okay, the most common will be the lungs. And in the lymphatic metastasis, the most common will be the obturator group of a lymph node. Obturator group of lymph nodes. Okay. So these are all about your prostate cancer. Okay. Yeah. Now come to the bladder stone. ठीक है, ये खत्म कर देंगे उसके बाद. I think any questions we have? Yeah, we have some questions. So let's first ये urinary bladder करने के बाद, and only the kidney and ureter is remaining there, we will do the next part. Okay. So urinary bladder में सबसे पहले जो important है, that is about your primary bladder stones and the secondary bladder stone. So इतना सिर्फ आपको याद रखना है, the differentiation. Primary bladder stone, more commonly in the children, especially in the developing countries due to the nutritional deficiencies, endemic in the low-income areas, often with ammonium acid urate or the calcium oxalate. Okay, ammonium acid urate or the calcium oxalate. Associated condition will be the malnutrition and the early weaning. Secondary bladder stone, most commonly in the adult, most common cause will be the benign outlet obstruction. Okay, benign outlet obstruction. Other than this, Foley's catheter, bladder diverticula, these are the other factors. Most commonly, especially in the aging males. यहाँ पर most common composition will be the ammonium acid urate calcium oxalate. This will be a mixed stone or the Staghan calculi, that is your two white stones. Okay. And obviously the clinical features, in case of the clinical feature, there is a pain while passing the urine, terminal hematuria, or there is a severe pain at the end of the micturition. All the symptoms of the sarsaparilla you will find in the secondary bladder stone. Okay, so one of the good remedy is sarsaparilla, because if you go with the clinical feature of the sarsaparilla, that is pain at the end of the urination, terminal hematurias. Okay, so these are the clinical feature of the secondary bladder stones. Okay, and yeah, the ultrasonography, how will you diagnose? With the help of the ultrasonography, you will see a characteristic shadowing, and most the bladder stones are the radiolucent. Okay, most of the bladder stones are the radiolucent. ठीक है? So, so if they ask you the question, most common renal stone is calcium oxalate, And the most common, the bladder stone will be your uric acid stones. Primary will be the ammonium acid urate stone, and most common stone in the prostate. There is a prostate stone also. Here the prostate stone will be the calcium phosphate. Okay, calcium phosphate stone. So calcium phosphate stone is the most common stone in the prostate. Okay. Okay. Now I have when you were studying the surgery in the last year, we have done the melanchoplakia. Okay. Can you just tell me the answer of this? Which of the following histological finding is pathognomic of the melanchoplakia? Forshman bodies, Michel Gutmann bodies, Red Sternberg cell and Sama's bodies. इसके बाद हम लोग पढ़ेंगे what is melanchoplakia. Yes, the answer is your Michel Gutmann bodies. Okay. Michel Gutmann's bodies. So this is, remember this, Shoshaman bodies seen in the sarcoidosis. Okay. Red Sternberg cells seen in the Hodgkin lymphoma. Sama body seen in the papillary thyroid carcinoma of the body and the papillary thyroid carcinoma and the ovary carcinoma. Okay. So now come to the, what do you mean by the melanchoplakia? याद रखना, macrophage malfunctions. Here, the person is suffering from the repeated urinary tract infections. Why? Because the patient is immunocompromised. How is it immunocompromised? Either he is suffering from cancer type of diseases, he is diabetic, he is HIV positive, or whatever. He is an immunocompromised person, or he isn't taking lot of steroids and did transplantation, anything. The immunocompromised person who is suffering from the repeated UTI infection. The person is suffering from the repeated UTI infection because of the inadequate killing of the bacteria. Inadequate killing of the bacteria. There is a formation of the small nodules all over the bladder. This nodules is made up of the histocyte cells. Okay, large histocyte cells. Now this large histocyte cells, okay, von Hanselmann cell, this consists some bodies, which bodies are known as our Michel Gutmann bodies. Okay, so there will be a suffering in the woman who's suffering from the repeated urinary tract infections, or patient with melanchoplakia, he's immunocompromised. Okay, and what you will find in the ultrasonography? In the ultrasonography, it will see you will a mass type of thing is present which causes an obstruction, and you will go to the culture. The culture will see a bacteria, E. coli bacteria. The patient is taking antibiotic but still is not relieving, but because antibiotic resistance type of the thing. So all this due to the immunocompromised. Okay, so ये याद रखना, macrophage malfunction and the Michel Gutmann bodies. ठीक है. Now come to the bladder rupture. Okay, so this is one of the thing. There are two types. One is extraperitoneal and the other is your intraperitoneal. Okay, so extraperitoneal and the intraperitoneal. So extraperitoneal is mostly due to the pelvic fracture, and here it is due to the blow to the full bladder. Blow to the full bladder. Site moved in the lateral wall. Here in the intraperitoneal, which is mostly in the dome. Urine leak around the bladder. Abdomen is usually normal. Here the urine leak into the peritoneal cavity. So there is an peritonitis. Okay, so there is an peritonitis. So what you will see in the extraperitoneal, remember extraperitoneal is more common. About 80% is extraperitoneal and the 20% is your intraperitoneal. Okay. If you go with the cystogram, of a bladder rupture, in case of bladder rupture, you do the cystogram. Here you will see a flame sign or a Pierce sign. Okay, so remember this flame sign, Pierce sign, these are the sign of the bladder rupture, especially in the extraperitoneal fracture or rupture of the bladder. Okay. Whereas in case of your intraperitoneal, there will be a triad. The triad will be because of this blow to the bladder. There is a pain. Okay, suprapubic pain, difficulty in passing the urine. Okay, difficulty in passing the urine. So urine difficulty plus and hematuria. Along with that, there is a distension in the lower abdomen due to the because urine leak into the peritoneal cavity. So there is a peritoneism or abdominal lower abdominal distension. Okay, and here you will find a X-ray. X-ray will shows you X-ray of the lower abdomen will give you a ground glass appearance. Ground glass appearance. Cystography, the gold standard in this case, if you do the cystography, you will see a sunburst appearance. Okay, sunburst because there is an bursting of the urine into the peritoneal cavity, sunburst appearance. Okay, so this is all about your bladder rupture. In दोनों को याद रखना. Okay, what is the bladder rupture? Now, tell me, this is about your bladder carcinoma. 60-year-old male present with a painless hematuria. He has a history of working in a dye industry. Which carcinogen is most likely responsible? Calcium phosphate in prostate, calcium phosphate stone. Okay, I'm writing it here. It is calcium phosphate. Okay, so here the answer will be aromatic amines. Okay, it's a feature of painless hematuria. Painless hematuria, 60-year-old man working in a dye that is aniline. Okay, factory is the most common. This is your CA bladder. CA bladder. Okay, and the most common type of the carcinoma will be the transitional cell carcinoma. Okay, transitional cell carcinoma. Okay, so this is basically the one of the most common clinical feature, painless hematuria. Usually, cause will be the multifactorial, but most commonly the person who is working in a dye industries, aniline dye. So here the aromatic amines is the most common factor. So this is the most of the carcinogen most likely to responsible for this. Okay. Now, most common histological type of the bladder cancer worldwide. The answer will be your transitional cell carcinoma. Okay. Now, most common presenting symptoms of the bladder cancer. Remember, the bladder cancer hematuria is there, a lot of hematuria, but that will be a painless hematuria. Okay, so answer is here the painless hematuria. Now, gold standard diagnosis for the bladder cancer. So, what is the gold standard diagnosis for the bladder cancer? Is it ultrasound, cystoscopy with biopsy? Okay, so answer will be your cystoscopy with biopsy. I'm going fast because yeah, the answer is this, cystoscopy with biopsy. So most common symptoms क्या है? Most common symptoms है painless hematuria. Okay, now bladder cancer most common metastasis कहाँ पर होगा? Basically in via the blood, it enters into the visceral, in the liver, and then into the lung. Okay, and the lymphatic node source, basically pelvic group of lymph node, most commonly in the obturated group of lymph nodes. Obturated lymph nodes. ठीक है, चलिए हो गया. So let's move to the renal calculi. Okay, we will finish this by today, the whole like kidney and the ureter. Yeah, बाकी आप लोग थोड़ा बहुत है वो कर लेना. तो Mark this one. Calcium oxalate, most common type of the stone in renal calculi, radio-opaque है. Calcium phosphate, radio-opaque, often seen with the oxalate, associated condition with the renal tubercular acidosis, also in the prostate stone. ठीक है. Uric acid is your radiolucent, seen in the acidic urine. The person suffering from gout, high purine diet, they suffer from the uric acid stone. And number one is bladder stone का सबसे common stone क्या है? Uric acid stone. The other is your two-white or the triple phosphate stone, consists of three types of, that's magnesium, ammonium, and the phosphate. They look like a staghorn, usually in the alkaline urine. Okay, and here the most person who is suffering from the UTI infection, they usually suffer from the stupide triple phosphate stone, and the bacteria which is responsible for the Klebsiella and the Proteus, not the E. coli. ठीक है, not the E. coli. Among this, most common will be the calcium oxalate. Okay, most common will be the calcium oxalate. Okay, and other is your cystine stone. It is associated condition will be the inherited tubular defect. They are mostly recurrent in children, genetic and the hexagonal crystals. ठीक है, ये थोड़ा याद रखना. The painful will be the uric acid stone. ठीक है, uric acid stone. Remember, the where the stone it is present, the type of the stone will determine you whether it is painful or not. Most common symptom is pain of renal calculi, but the most common painful stone is your uric acid stone. Okay. So severity of the stone does not depend upon the size. It depends upon the type of the stone. Declare the most common, most painful is the uric acid. हो गया? ओके. So I think this you can give the answer, column A and column B. Calcium oxalate stone, uric acid stone, stovite stone, and फटाफट answer दे दो. Calcium oxalate stone is most common type of the kidney stone. You are seen in genetic defect, hexagonal crystals, uric acid stone, or associated with insect. फटाफट आप answer दे दो because it is very easy to answer. उसके बाद you give the answer. तब तक I'm just writing it here. Suppose this is stone. You give the answer, हाँ? Answer लिखो, आराम से answer दो. ठीक है? If you give the answer, I'm just waiting for this. Let's see किसी ने आंसर दिया है कि नहीं है. 1 minute. Okay. So calcium stone is the most common stone. ठीक है? Uric acid stone is radiolucent. White stone is associated with, I'm going too fast or what? Just tell me in the chat box, okay? Cystine stone is seen in the genetic defect. Okay? Got it? Yes, A3B2C1D4 मिला लो. ठीक है, क्या है? A3B2C1D2. Good, very good. Now see this picture. ठीक है, ये kidney है, and my drawing is very bad. It's like it's very hard to draw here. Now this is kidney, this is ureter. Now suppose stone is into the upper part of the ureter, the pain is related to testes in male, and in the female it is labia majora. ठीक है? If the pain is in the mid ureter, okay, the pain is goes into the iliac fossa, mimicking to appendicitis. If it's pain in the lower part of the ureter, the pain goes into the thigh and the scrotum. So depend upon the patient comes to your clinic, and if they say you, madam, I have pain only in the back, तो मान के चलो the renal calculi is mostly into the calyxes of the kidney. But if he's saying, madam, it's too much pain and the pain is going downwards, and I have to go to the urine every time. समझ में आ जाना, it is in the stucking into the ureter. Now, if it is saying up to the testes and the labia majora, then into the upper part of the ureter. Okay, my back will become low. So, got it? तो ये वाला diagram याद रखो. Upper part में होगा तो testes in labia majora in male or from female. Iliac fossa mimicking the appendicitis if it is in the middle part of the ureter. Yes, I can repeat it. So if the stone is in the upper part, the pain is radiating into the testes in male and labia majora in female. In the middle part of the ureter, if the stone is present here, it goes into the pain is radiate up to the iliac fossa. If the pain is into the lower part of the ureter, the pain will radiate into the thigh and the scrotum and the perineum. Okay? Got it? Chalo. So this is all about your renal calculi. So that is the answer, correct match. Now come to the pyonephrosis. Nephrosis, a suppurative infection in the renal collecting system with the pus is called your pyonephrosis. Okay, this can be due to anything, due to stone or stricture or anything. Okay. So let's move to the, इसको करके खत्म करते हैं, genitourinary tuberculosis. If I'm putting it here. Yeah. So can you tell me the answer of this? उसके बाद ये क्वेश्चन आंसर करके ये फिनिश करते हैं, genitourinary tuberculosis. Just give me the answer. Very good. The answer is genitourinary tuberculosis. ठीक है. Number 1 याद रखना, genitourinary tuberculosis में urine culture is always negative. So इसलिए there is it is also sterile pyuria. Pus is there, but when you check or when you investigate it, or okay, the urine when you culture it, it will be the negative. You won't find any bacteria. So sterile pyuria is a clinical feature of the genitourinary tuberculosis. Okay. Okay. तो ये एक symptoms याद रखना, sterile urea is a clinical feature of the genitourinary tuberculosis. Or remember, the genitourinary tuberculosis, in case of your kidney, okay, it is always secondary part. Primary will always be the lungs. So via the hematogenous route through the lungs, it affects the genitourinary tract. Okay. Now come to the most common site of involvement of the genitourinary tuberculosis. ठीक है, आंसर लिखो, तब तक यहाँ पर मैं कुछ लिखती हूँ. ओके. Just give me the answer. Most common site of involvement of the genitourinary tuberculosis. Let's go to the answer. The answer is kidney. I told you the primary site will be the lungs, and from the hematogenous route it reaches into the kidney. ठीक है. So बाकी का जो है ना, that is urinary, bladder and prostate by the ascending way, not with the any hematogenous route. Remember, genitourinary tuberculosis, testes is always paired. Okay, testes is paired from the TB. Ureter, bladder and the prostate, they also suffer from the tuberculosis with the ascending infections, not by hematogenous or other route. So kidney, basically hematogenous route, that is a kidney is the primary source. Uske baad prostate, other the urinary bladder, ureter. Okay, they involve, rest of the organs are involved by the ascent or descent, except the testes. ठीक है. Now characteristics radiological finding in the renal tuberculosis. Characteristics, radiological finding in the renal tuberculosis. तो हम लोग ने क्या पढ़ लिया? प्राइमरी सोर्स है लंग. From there, it goes into the kidney or the prostate by the other by the ascent or descent, except the testes. Okay. Second, the sterile pyuria is a feature of the renal tuberculosis. Okay. So just give me the answer of this. Let's see क्या आंसर है मिला मुझे. Okay. So here will be the putty kidney. ठीक है. The answer is a putty kidney. जैसे कि ground glass opacity seen in where? Interstitial lung diseases. ठीक है. Interstitial lung diseases, we know that. Soap bubble sign, it is seen in the soap bubble appearance. Bone cyst, aneurysm, bone cyst. ठीक है. Aneurysm, bone cyst. Soap bubble appearance. Varroa sign seen in the Crohn's diseases. Okay. In the Crohn's disease. Or the hypertrophic pyloric stenosis. Okay. Hypertrophic pyloric stenosis. Okay. HPS, hypertrophic HPPS, pyloric stenosis. अभी क्या रहा बाकी? That is your putty kidney. So now telling you know how is the putty kidney is formed. So basically this is a diagram of the kidney and these are the calyces. There is a formation of the granuloma in the renal pyramid. Okay, because TB affect now in the kidney. Okay. Now this, it forms a large abscess in one of the pyramid. It forms a large abscess. Now this abscess bursts and they enters into the ureter. Okay, enters into the in the ureter. Okay, and when it goes and via the urine it comes out. So this is basically when you culture it, the urine, there will be a pus, but when you culture it, you won't find any bacteria. So that is in sterile pyuria. Okay. Now what happened? Because of this, there is an sometimes there is a calcification. The complications of this, there is a calcification in the pelvic ureteric junctions. Suppose there is a calcification in the pelvic ureteric junction due to repeated granulomar infections. As a result, what happened? The urine cannot passed out through the ureter, and there is a formation of the hydronephrosis. Okay. There is an hydronephrosis and the pyonephrosis. Okay, formation of the pus within the kidney. There is an accumulation of the urine within the kidney. There is a kidney urine ratios increases. Okay, now what happened after this? There is an abscess is there. The abscess cannot get burst out because of this calcification in their area. Now this kidney is replaced by a caseous material. Okay, now this kidney is replaced by caseous material. Caseous material. Now this caseous material, basically the calcified material, which is called a putty kidney. ठीक है, इसको ही the calcified kidney is called a putty kidney. Okay, a calcified non-functioning kidney is an end-stage kidney and this is called a putty kidney. ठीक है, got it? Here the answer is your putty kidney. So this is all about your genitourinary tuberculosis. Kidney becomes shrunken, non-functioning, appears like a chalk putty, and there will be get the putty kidney. ठीक है? Most common symptoms will be your frequency of the micturition. Frequency of the micturition. This is the most common symptoms. ठीक है? So और भी कुछ है. Let me show you one thing. Yeah. So when it affects into the bladder, when the tuberculosis affects the bladder, okay, so suppose it affects the bladder, it forms a tubercle within the bladder or nodules within the bladder. Okay, now this time this is known as your thimble bladder. Thimble bladder, that is fibrosis of the bladder or the thimble bladder. Okay, earliest symptoms or the common symptoms will be the same thing, that is the frequency of the micturition. This is the common symptoms and also the earliest symptoms of the genitourinary tuberculosis. Okay. So this is all about your tuberculosis in the kidney and in the bladder, and when it affects the vasa deferens, okay, when it does not affect the testes, when it affects the vasa deferens, it forms a beaded type of the appearance, okay. So large calcification and the prostate, and there is a beaded appearance in the vasa deferens, okay, the vas deferens. So beaded appearance in the vas deferens in the in tuberculosis, and the thimble bladder is also seen in the genitourinary tuberculosis. ठीक है, आज इतना ही करते हैं. नेक्स्ट कार्सिनोमा का ज्यादा नहीं है, अभी यहाँ तक छोड़ते हैं बस हम कंटिन्यूअसली. उसके बाद वी विल स्टार्ट विद दी टू से वी विल स्टार्ट विद द endocrine surgery. ठीक है, anybody have any questions up to this? Because I just wanted to finish because within April. Chalo. Anybody have any questions? You can type me in my phone number if you have. You can ask me the questions directly there. और so next time मिलते हैं, ठीक है? और उसके बाद we will do the what to say your endocrine surgery, and कुछ करो बाकी है एक दो, उसको खत्म कर देंगे. ठीक है? ओके. इसके बाद कोई क्लास है आप लोगों का? इसके बाद या दिस इज ऑफ माय क्लास इज द लास्ट क्लास है? चलो. ओके, सो थैंक यू एवरीवन. Last class will be next class will be in the Saturday or Sunday. We will let you know. ठीक है? Anybody have any questions? ठीक है. So let me know how is the class. If I'm going too fast or not, let me know. Okay. And is this the way should I teach, or should I I will go into the not in an MCQ base? Just tell me in the chat. ये तरीका सही है आपको लिए या MCQ by see I don't take repertory class. Oh sorry, in the next class will be a repertory class. Okay. So ठीक है, नेक्स्ट क्लास सैटरडे या संडे को आपका होगा तो सर्जरी विल स्टार्ट विद द एंडोक्राइन वन. ओके, सम पार्ट बाकी है उसको साथ करवा लेंगे विद एंडोक्राइन. ठीक है, तो चलो, थैंक यू देन. Yeah. Okay. So we will do in a MCQ ways only so that it will help you to remember the this. अभी रेनल कार्सिनोमा बाकी है, उसके बाद चले जाएंगे डायरेक्टली एंडोक्राइन में. ओके, इसमें थोड़ा बड़ा है. It will मैं 3-4 क्वेश्चंस बनाने हैं, so that is why I hold it for today. In the next class we will do. Okay, चल, bye.